The septum has been prepared with an injection at the incision site of 2% lignocaine with 1 in 80,000 adrenaline. We do not inject elsewhere in the nasal mucosa. A vertical mucosal incision is made. This is best made by retracting the lower edge of the upper lateral cartilage laterally with the back of the 15-degree blade. The incision can be curved inferiorly as the nasal floor is approached to prevent the flap from tearing. The bloodless submucopericondral surgical plane is identified. We suggest using a sharp instrument for this. We use the suction curette. Once the plane is identified, it is easily lifted off with a suction freer in a superior to inferior sweeping direction. The freer tip should always be angled towards the cartilage of the septum to avoid injuring the mucosal flap and causing a perforation. Continue raising the flap beyond the osseo-cartilaginous junction. This can be felt as a transition from the smooth cartilage to the rougher bone of the ethmoid plate. An incision is made in the cartilaginous septum just anterior to the deviation, or to the osseo-cartilaginous junction. We use the sharp end of the non-suction freer's elevator. The incision is made at least 1.5 centimeters below the roof of the nose to preserve the keystone area of the attachment of the quadrilateral cartilage to the ethmoid plate. Failure to do this can decrease the structural integrity of the septum and lead to saddling, which is an unsightly cosmetic complication. The suction freer is again used to enter the submucoperiosteal plane on the contralateral side, completely isolating the bone from its septal covering. Further incisions are made to allow excision of a window of cartilaginous septum. Horizontal cuts are made with sinus scissors at the superior and inferior margins of the septoplasty. An Irwin-Moore or Lux forceps is used to remove the deviated cartilage. When removing cartilage behind the head of the middle turbinate, caution should be exercised, and the forceps never used in a twisting manner to avoid injuring the cribriform plate and causing a CSF leak. A mucosal drainage hole is made as posteriorly as possible, typically on the contralateral side to the DCR. This is not shown in the video, but is done to avoid a septal hematoma from forming. 4-0 vicryl rapide interrupted sutures are used to close the anterior end of the incision. A quilting suture is prepared. The quilting suture is passed back and forth to oppose mucosa, ensuring bites are not too close together or tied too tightly.